Welcome everyone to the Truth and Fertility Podcast. So today I have something really special for you guys. I have my first interview and it is with a good friend of mine named Megan. She is actually a coworker of mine as well. She is a nurse at the OBGYN clinic that I work at and she's amazing. And so today I really just pick her brain on what it's like to work at specifically a NaProTechnology clinic. Now, if you have absolutely no idea what I mean by NaProTechnology, please pause this episode and go back just one episode before. I explain everything about what NaProTechnology is. So I really wanted to get more of the medical side of things and just an explanation of what it looks like when a doctor is treating a woman with NaProTechnology. And so again, like I said, Megan is a nurse. She works directly with the doctors at the clinic that I work at. And so we have an awesome interview for you guys to listen to today. Also, just a side note, my 3-month-old baby girl did join us for this interview and you'll hear her every once in a while. So just forewarning about that. But when you're a mom, you just, you do what you got to do. So thank you for your patience with that. But I think you are really going to enjoy our interview today. Welcome to the Truth and Fertility Podcast. My name is Haley and I am your host. I work at an OBGYN clinic where I teach women and couples how to chart their cycles so they can either achieve or avoid pregnancy and also to manage their fertility. I have a huge passion to teach women and couples about the beauty of their fertility and how the pill is never the answer to women's health. There's a lot of good and not so good information out there about fertility. And so my goal with this podcast is to help you sort out the truth from the weeds. I want to teach you how to chart your cycle and to reach your family planning goals while also even possibly locating hormonal imbalances and to receive proper treatment. I want to help you get in the best hands that you can with the best doctors that you can to reach optimal reproductive health. So if you're ready to get on this journey with me to learn more about your reproductive system, how it was created, and how it should be working, and the best medicine in order to make it work if it is not, you are in the right place. I pray that this blesses you, so let's get to it. Today I have a very special episode for you guys. I am interviewing Megan tonight. She is a really good friend of mine, and she actually works at the OBGYN clinic that I work at. I teach women and couples how to chart their cycles at this OBGYN clinic, and it has a lot to do with the health and just healthcare in general of what is offered at this specific OBGYN that we work at. So Megan also teaches women and couples how to chart their cycles, but more specifically, she is a nurse. And now she's working at this clinic that specializes in what's called NaProTechnology or natural procreative technology. So it's a very different kind of OBGYN clinic than you may have ever come across or have even heard of. And so I wanted to bring her on today to really just talk about her experience working there, what she does differently as a nurse working at this specific OBGYN rather than what she would be doing at other places. So anyways, I have been talking a while, so I want Megan to introduce herself. Megan, just tell me a little bit about yourself, where you're from, what brought you into nursing, and what brought you to this specific clinic.
Yeah, thank you so much, Haley. I'm so excited to be here on your podcast. I am a day one fan. I've been watching since the beginning, so it's an honor to be here. But yeah, I have been working as a nurse for, it'll be a year in November, which is crazy. I'm originally from Minneapolis, Minnesota. I spent 4 years living in St. Louis, going to nursing school, and now I'm here in Arizona. So yeah, it's been great. As far as how I became a nurse, I feel like my whole life, middle school, high school, I kept hearing people say, like, you would be so good in healthcare because, you're really good with people, but you're also very science-minded. And so I kind of always had it in the back of my mind as something that I might want to do. And I've just had a few different encounters, like working at nursing homes and doing things like that, where I'm like, maybe I would like doing healthcare and really I think my biggest passion behind nursing is really caring and meeting patients where they're at and having that kind of building that relationship with them. And I'm really blessed to be able to do that in a pretty unique setting at the office that we work at, because I do get to build relationships with a lot of the patients that we work with. So I also teach couples how to chart their fertility, as well as do other roles at the office as well. So I kind of have a unique take on that. And kind of what brought me to the office was really their strong stance of pro-life. I always knew that I wanted to work in healthcare, but it can be kind of a tricky thing when you are pro-life minded and you have really strong beliefs in that, because a lot of modern healthcare really doesn't. And so it's kind of finding that space where you feel comfortable morally to practice healthcare.
Awesome. Oh, that's great. Okay. So going on like with the pro-life topic and everything, because a lot of what being pro-life is obviously, against abortion, and really what brought you to this clinic was because you knew it was pro-life, right? Mm-hmm. And so when you got to the clinic and you started working there and you started to recognize, okay, like, yes, it's a pro-life clinic, but I think it even goes further than that, where this clinic doesn't prescribe contraceptives, and it teaches, like, there's people on staff like you and me that teach people how to chart their cycles. And, we practice medicine differently because of that. So tell me a little bit about that. Like, what are you doing differently being a pro-life nurse? So just kind of tell me what it's like doing that.
It's been a really unique journey, because obviously I came to this office because it is pro-life, and it's been kind of an interesting journey, because I myself, just like growing up as a young, teenager, a young girl, I never really struggled with like difficulty with my cycles. Everything was pretty normal. And so I really didn't have a ton of experience with that, like I know you did when you were younger, with irregular cycles and things like that. So I wasn't super familiar with a lot of the like NaProTechnology and all of that in my own life. And so part of this job, before I started, the office sent me to training for this NFP, and that's actually where Haley and I met.
Yep.
So crazy, but it was just like really eye-opening to have, I think we were there for what, like 9 days?
Yeah.
8 days,
I think,
something like that?
No, I think like 10 or... The first one was like 10 days, I think.
It was a
over
long
a week.
time.
Yeah.
We got a lot of information, and my eyes were really open to just how much science is behind this. And of course, like it would be, but just the efficacy of a system like this, I feel like, especially when I was in nursing school, there was kind of like, they would explain the different methods of family planning, right? And they would be like, okay, there's like this kind of contraceptive, whatever. And then there's also like the calendar rhythm method, but anyways, moving on. And so it wasn't given a whole lot of like time or explanation. And so going to that course with you and learning about kind of the whole data behind natural family planning was just amazing. And how it really does work. And how effective the system really is. And so anyways, came in with a lot of that knowledge, and I'm super grateful I got to go to that training and learn all of that. And it's just been really neat to see. Obviously, I get to do the natural family planning teaching, but also to see some of the like labs and ultrasounds and things that we order at the office. And so kind of getting to see where the two of those intersect has been pretty neat.
Yeah. Okay. So that's exactly where I want you to hone in on right now, because I'm even interested in that, not being an actual medical provider. Like I want to know, okay, like when a client goes, let's just say a woman goes to your clinic and she's got whatever it is, like irregular cycles, painful periods, whatever it is. And oftentimes when that happens, the PA or the doctor will tell them, okay, let's get you charting your cycle to figure out what's going on. So that's like on my realm, right? Like I teach them how to chart their cycle, but then on your realm, what else is done because of that? So like, is there anything different that this specific OBGYN clinic does that you do that's maybe different from other OBGYN clinics, and really trying to figure out the root cause of what's causing that? Because we don't just slap the pill on them. Like we actually really try to find what's causing that.
Yeah. So a lot of times they'll order for patients that have kind of like irregular cycles, some different lab work, and we call it post-peak testing is kind of the title for it. And this we order a lot for patients. It's testing your progesterone and estrogen levels after you've ovulated. Because I know, Haley, you've talked about kind of the different hormones that are at play during the menstrual cycle, but at the post-peak phase, progesterone should be the dominant hormone instead of estrogen, which was the dominant hormone in the pre-ovulatory phase. So they have patients go to the lab and get blood work done on your peak +3, peak +5, peak +7, peak +9, and peak +11. Yeah. And it kind of gives the provider a way to look at the rise and fall of progesterone and estrogen in that post-peak phase, and to see, does it taper off too early? Does it not get to the right point where it needs to get? And then based on that, then they can have the patient start like a progesterone supplement if needed in the post-peak phase. So that they order a lot for patients. And I think that that's super important, because patients that are being seen perhaps at other OBGYNs, they'll be like, let's get your hormones tested, and they have them draw estrogen and progesterone levels on some random day of the cycle, and it's like, that's not going to give you a lot of data, because if you don't know when in the cycle this was drawn, the hormones are supposed to be different at different points in the cycle, right? So if you're like, oh, progesterone is low based on this one lab that we drew at this one time in your cycle, it's not really necessarily indicated to prescribe progesterone, because what if they had the lab drawn in the pre-ovulatory phase and progesterone is naturally low? And so, you know, that's a whole nother thing of like, we got to prescribe the progesterone at the right time of the cycle. And so having the correct data really, really helps with that.
Okay, so backing up then for a second. So when you're doing all that lab work, you know, so peak, for those of you that don't know, in kind of like the natural family planning world, there's what we call a peak day. So a peak day is really based on the mucus signs that you're seeing. It's the last day that you see like just the really crazy slippery, clear, egg white type mucus. And so that's the best guess of around the time of ovulation. So what you're telling me is that when a woman is coming in and you're wanting to look at her progesterone, you're not just testing it on one given day. Even if they are, let's say they are post-ovulatory when they're getting their blood work done, it's still not only on one day. You're testing it
usually
days.
It's going to be the 5 blood draws. Sometimes they'll have them get the labs drawn on peak +7, kind of right in the middle, if it's not practical for them to be able to go to the lab 5 different times, because that is kind of a lot. But that gives them the full post-peak testing, but sometimes they'll just order peak +7 just to get kind of especially once they've been working with the client for a while and, you know, seeing them, they can just do the peak +7 and see kind of where they're at in the middle of that post-peak phase.
Okay. So then what would the best case scenario be? Like when you're doing all of that blood work, you know, on every other day in that post-peak phase, like what is the doctor wanting to see that's going to reveal like good levels of progesterone? Like what's the best case scenario there?
Yeah, so you want to see that appropriate kind of rise and then fall of progesterone. So I can't quite remember what the exact number is that they're trying to get to, but I just know that they're wanting to see kind of the rise and fall, and also seeing that progesterone is the dominant hormone of the post-ovulatory phase, as it should be.
Yeah, and that it's like it's staying high enough and long enough, right?
It's not tapering off too soon. Yeah. And if it does show that, then perhaps they would talk about doing a progesterone supplement to help with that, and then retesting the labs to see, because usually when progesterone is being prescribed, it's typically only prescribed during peak +3 through peak +12. It's kind of the same thing I was just talking about with, we wouldn't just say, okay, take progesterone every day of your cycle, because progesterone's not always supposed to be high. It's supposed to be this ebb and flow of progesterone and estrogen. So if, you know, a doctor is prescribing a progesterone supplement that a woman's taking, you know, every night, then progesterone's always high, and so then that's not really fixing the issue.
Right. That's not even going along with what
the normal body is supposed to be doing.
What her hormones should be doing. Okay. Yeah. So when a woman is taking those progesterone supplements, if she finds out that her progesterone is low, then she would have to be charting, I'm assuming, then, in order to figure out the correct timing. Yeah,
it's really important. That way you know, because as you've probably talked about, sometimes, you know, we don't always ovulate on the 14th day, right? So sometimes that pre-ovulatory phase can be longer, and so in that case we would want to know, okay, when is your peak day, so that way we can do peak +3 through peak +12 for the progesterone. So it is really important to have that knowledge of your cycle, especially for women that may have irregular cycles or longer cycles, things like that.
Yeah.
You know.
Okay. Oh, that's awesome. Okay, so with the Peak Plus 3, 5, 7, 9, 11 testing, okay, so you have that for, and that's if somebody is showing signs of low progesterone, right?
Yes.
Okay, so what are some other things, too, that you might do working at this clinic in a NaProTechnology world that other clinics might not do?
Yeah, so another kind of testing that we do is what's called the follicle series, and that's an ultrasound series that patients come to do at the office. So basically what that is looking at is you're following that follicle that's growing on your ovary, and you're watching it. So you're coming into the office, usually it starts out like every 2 days, 3 days, as it's getting bigger, and we're waiting for it to get to that 18 millimeter mark, which is when it's mature. So as we're getting closer to that point, then the patient starts coming every day for ultrasounds, because we're trying to capture that rupture to see when it ruptures. So once that follicle gets to 18 millimeters, then we want to do an estrogen lab draw as well to see where your estrogen level is at. And usually we're looking for that to be greater than 200.
Okay.
And so some women then at that point, that's, all the data we're trying to get. Other women will do, understand, okay, this is right when you're going to ovulate, so this would be a good time to have intercourse if you're trying to achieve a pregnancy, or if women are going through other, taking other medications at that time, like HCG injections, things like that, so forth, whatever the plan of care is. But it's been really neat to kind of see patients through that follicle series and to be able to see the rise of that follicle and then the corresponding rise with estrogen levels as that follicle is getting bigger.
Okay, gotcha. And so what would be a sign that a woman might need this follicle series done, like this type of testing? Like what would be, is she worried she's not ovulating? Like what would be the main reason for that?
Yeah, so definitely if there's concern that a woman's not ovulating, if there's concern that the follicle's not truly rupturing for whatever reason, or just for couples that are having difficulty achieving, kind of being able to pinpoint, okay, this is when you're ovulating. And then sometimes they'll even have women come in for a Peak Plus 4 ultrasound to see if there's a corpus luteum formed.
Okay, so explain that.
Yeah.
Go back to basics really quick. What is a corpus luteum?
So a corpus luteum, so after the follicle ruptures, the remnants of the follicle form what's called the corpus luteum, and that's kind of just a fancy word for yellow body. Okay. And the corpus luteum is responsible for producing progesterone. So at Peak Plus 4, you should have ovulated by that point. Peak is kind of a rough estimate of when you're ovulating. It could be up to 3 days after the peak day that you truly ovulate. But by Peak Plus 4, 4 days after, you should have ovulated. So we should see a corpus luteum cyst on an ultrasound. So that could be kind of confirmation that you did ovulate that cycle.
Okay, gotcha. So in that case, would they only be doing an ultrasound on Peak Plus 4, or would they have gone through the whole follicular series first?
Kind of depends on the patient. I'd say both. Kind of depends also, like, practically on people's availability. If they're able to come for all these ultrasounds, or if you just want to see, okay, did you ovulate? We'll have you come on Peak Plus 4. So it kind of just depends on the patient. But yeah, so they can actually see, okay, did this corpus luteum form? Did you actually ovulate? So yeah.
Okay, so when you're seeing these patients doing these follicle series for, worries that they're not ovulating, or if their ovulation just isn't a good ovulation or whatever, what are some of the treatments that you've seen the doctors doing to those clients that do end up seeing, based on that ultrasound, that, okay, maybe they're not ovulating or they're having a poor ovulation? Like, what are some of the things that you've seen the doctors do?
Yeah, so kind of depends on the client and obviously like things that they've tried in the past, things like that. I've seen prescriptions like letrozole or Clomid prescribed, and they would take that usually like at the end of their period, like cycle day 5, 6, 7, somewhere in there. I've also seen what's called a trigger shot or an HCG injection that patients are given. That's usually, so when we were talking about that follicle series, the follicle has reached 18 millimeters in size, and then we would let the patient know this is a good time to do that HCG trigger injection, and so you should ovulate 12 to 24 hours from when you had that injection.
Okay, so that's just to kind of spark ovulation, basically. Yeah. Okay, gotcha.
Yeah.
All right, yeah, that's so interesting. Can you think of anything else off the top of your head that's different that our clinic does on the medical side of things.
Yeah. Well, I know you touched on this briefly in one of your videos, but talking about using progesterone for postpartum depression is a big thing that we do that not a lot of clinics do.
Okay. I want you to talk about that right now because it is so important.
Yes. Okay.
Tell me everything you know about that.
Yeah. So progesterone can be given to help with postpartum depression. A lot of women will come in with these symptoms and they're prescribed, an SSRI or like a common antidepressant medication when it's really just corresponding to the plummet of progesterone after the woman has delivered. And so helping to give her a boost of more progesterone can actually help with mood. And so usually the patient will come in and the initial progesterone is usually like 200 milligrams, and then the patient, if they're feeling really good after that, they may not need any more, or they may go home and do the full series where they're doing 5 more injections of 100 milligrams every other day.
Okay, gotcha. So, yeah, and the reason I got so excited when you said that is because for our listeners, I actually did that with my, that you heard her right now, with my third baby who's joined us for this podcast. I've had a whole journey with postpartum depression with every single one of my kids, but it was with this third one that I just had where I was offered that like full progesterone shot series, and I've never felt better in postpartum than with my other two. Like it was night and day. So I'm glad you mentioned that.
So in addition to using progesterone therapy for postpartum, another thing that we do at the office is use progesterone therapy for when a woman has a luteinized unruptured follicle. So the ovulation did not quite go as it should, and so now a woman's having a very painful cyst. So usually the patient will come into the office, we'll kind of confirm that there is a cyst on the ovary.
You confirm that with ultrasound? Okay.
Yeah, so they'll have an ultrasound done, and then once that's confirmed, we would give the patient a progesterone injection, usually like 100 milligrams, and it helps to dissolve that cyst and also to help remove the pain, obviously, that they're having.
Okay.
And so that's another thing that we use progesterone for. So we use it a lot in the NaProTechnology world with the post-peak progesterone supplements, obviously use postpartum, and then this use as well. So but I think the biggest thing with this, and kind of circling back to what I said earlier, is that we're using progesterone adequately according to the woman's cycle.
Right. Yeah, and so according to her cycle, meaning she should be charting while she is taking that progesterone, so you know for sure when she's post-ovulation, post-peak.
Yeah, exactly.
Okay.
And we kind of like touched on that earlier too, I think. Just like making sure, because some women, the pre-ovulatory phase is longer that month for whatever reason, and that can happen to any woman at any time, and so it's important to know when you are post-ovulatory and to take that progesterone at the correct time.
Okay. So if a woman is having issues with like painful cysts or something on her ovaries, she'll usually come in just from that symptom of pain, and that's how you'd find that luteinized unruptured follicle. Okay.
Yeah, she's having, ovarian pain.
Gotcha.
Come in for an ultrasound.
Yeah. So explain really quickly again, what is a luteinized unruptured follicle? So isn't it when basically like progesterone rises, but the egg didn't actually leave the ovary leave the follicle?
Yeah. Correct.
Okay. Gotcha. So you'd be using progesterone to kind of help with that pain if it's accompanied with pain. Yeah. Okay. Gotcha. Yeah. Okay. Oh, that's so interesting.
So I think just kind of to summarize everything that we've gotten the chance to discuss today, I'm really grateful for the time that I've had at this clinic, and I've learned so much, and a lot of this I really didn't learn in nursing school. So much of it I've learned in the last year of working alongside these physicians and being trained in NaProTechnology, being trained as a Creighton model instructor. I've just learned so much about the woman's body, and I'm really grateful, to like have this knowledge of my own body, and also to be able to share this with people around me, and just to educate them, because I think obviously we could do a whole other podcast on this, but just that like people, young women, are just not given all of this truth about their body, and it's so important. And so what a great gift that you will be able to hand down to your daughters, and myself, if I have daughters, to be able to hand that down to them. Like, what a gift.
Oh my gosh, it totally is a gift. Really quick, because you just put another question in my mind. So, going through nursing school, you said a lot of the things that you've learned in this, NaProTechnology world, working at this clinic, is not what you learned in nursing school. So kind of tell me like was everything new? Like, just kind of tell me more about that.
Yeah, I mean, obviously there's a lot of ground to cover in nursing school, and so women's health is only, you know, one semester, and we meet once a week, so there's not a lot of time anyways, and we got to cover, you know, gynecology and obstetrics. So there is that, but I mean, we definitely learned the, you know, building up of your lining and the shedding of that, and that's what's known as your period, but all of this stuff with the follicles and the cysts, and especially these different health issues that women have, definitely did not get that in-depth of training in nursing school on that, and so that's been really neat to see and to understand more about the like anatomy and physiology behind PCOS, endometriosis, etc. So that's been a really unique experience, and so it's definitely expanded my knowledge for sure, and just have more depth on medications that are used and different labs that can be done, and just kind of understanding behind all of that. It's been really amazing.
Yeah, well, and I think too, I mean, just in mainstream medicine right now, oftentimes when women are presenting with pain or with irregular cycles or with, you know, whatever it is that we're talking about, like, oftentimes they're just given the pill. And as much as it can help their symptoms, it doesn't actually get to the root cause.
Yeah, it's not really doing anything for you long term, because then when someday you do decide to come off the pill, you've got all of these issues that have been suppressed for years, and maybe even new ones that have developed in that time. And so it's important, I think, in the grand scheme of things. And you know, I think you've probably used this example, but just if someone comes in with a broken arm, we're not just going to say, well, you have the other arm, you're good, you know, you can, or we'll put a Band-Aid on it. And it's like, no, we're going to put on a cast and we're going to heal the arm. And so in that same way, I feel like women's health is the only area of medicine where we can really get away with this logic of just like putting a Band-Aid. You know, any other area of health, I feel like people would be like, you're crazy to not actually fix the issue that's at hand. This is the only specialty of medicine where they can kind of, you know, cheat the system a little bit and not actually figure out what's going on.
Yeah. And something I heard recently in a different podcast I was listening to is that so much money is being put into research on the pill. And if we were to transfer that money that's being put into research on the pill and transfer it into like, okay, how do we actually remove endometriosis? How do we actually fix PCOS? How do we actually get to the root cause of those things and understand more about what a woman's chart may be presenting? Like, if we put our time, money, and effort into that, I feel like we'd be so much farther along than where we are now.
That we know, and just like the in-depth stuff that you and I have learned from our training in the Creighton model of just like how much research and data has gone into this. I can't even imagine what they would do with those kind of funding and the time available. So oh my gosh. Well, such good stuff. Megan, thank you so much for coming.
So much for having me, and I hope that you all, learned something new today. And
I'm sure they did.
Yeah, this has been amazing.
Thank you so much, Haley.
I learned things.
Yes, love it.
All right, thanks, Megan.